Hi there, I am Julie Hirschberg. I am recording a little talk that I did for the Dystonia Medical Research Foundation Los Angeles support group, talking about neuroplasticity in dystonia. So now I'm recording it to share it with you today. And let me tell you about me, about Re+active. So I am a neurologic physical therapist. I own and started Re+active therapy and wellness in the Los Angeles area. And I'm an instructor at the University of Southern California. So I love the brain, love to learn a lot, read literature, talk to researchers about neurologic disorders, specifically dystonia, and then bring that to the world, share it with the people that I work with. At Re+active, we have the most amazing team. We have a team of 22 people. We have neurologic physical therapists, occupational therapists, neuropsychologists, personal trainers, yoga therapy, and we do in-person and telehealth sessions in California. We also host live online exercise classes for people with neurologic disorders and educate a lot of other therapists. It's one of my favorite things. This year, we also started a nonprofit, which is called Resources for Hope, to provide low cost care to people who don't have insurance or have a financial need. And I run a movement disorders fellowship with UCLA and Re+active for physical therapists to specialize in movement disorders. And particularly, I want to tell you that we run a dystonia program. So it's physical therapy, occupational therapy, and neuropsychology. And you can find it at reactivept.com dystonia program. So today, what I put together for this group was to talk very briefly about the evidence for therapy. And again, this is geared towards people with dystonia. I have a lot of other stuff that's geared towards therapists, but this is a really great resource if you have dystonia or if you want to educate others or other healthcare professionals about dystonia. We're going to talk a little bit about evidence. We'll talk about this neuroplasticity approach and provide a lot of examples of that and give some practical tips. So here's the evidence. I love to just grab some of the recent articles that I've been reading, and it's been great in the last couple of years. Overall in dystonia, we've got small studies. Okay, there's not large randomized controlled trials. And typically when I'm looking at these, I'm looking at concepts and theories and theoretical pieces that we can apply to practice. So I'm going to hit on a couple of these key articles as we go through. But what I think is really important is to look at the breadth of what's out there, from emotional well-being and pain, sensory motor training, motor control training, classifications of dystonia. There's a lot of great things out in the world of dystonia literature. And I want to start with focal dystonia. This particular graph here is from this article in 2018, including differential training with sensory motor retuning, that's SMR. And what I want to point out here, and this is what I share a lot with people with dystonia, is that what you see here in this particular training is that 80% of people had complete recovery. That gives me a lot of hope. That gives me hope to share with others. And then I want to know, well, why? What was it about this? And the sensory motor training is a huge theme in dystonia. That's what we do a lot as well. That's what's in the literature. But what they added here was a lot of variability. And I love that. And that's something really easy that you can add to therapy as well, is looking at variability. Okay, lots of other evidence-based recommendations, again, very small studies. And then on the other side, you can see what we're recommending based on our clinical expertise. We've been doing this for 10 years. We've learned a lot as well. So I want to highlight my favorite article by one of my favorite people, Nancy Beal, a lead researcher in this area, one of my first mentors and instructors in the field of dystonia. This particular article is from 2009, and it's still my favorite because she so nicely describes what was done here for focal dystonia. And what I want to emphasize is that it was intense. There was a lot, 3 hours a day for 5 days a week, then 5 hours a day for a week. And it included lifestyle, it included sleep, it included fitness, it included diet, it included brain health and fitness. So many wonderful things. This is, to me, a model program for dystonia. Some of the key components you can see here: a lot of positive expectation for improvements, graded exposure to the movements, starting with imagining them, improving sensory discrimination, and getting a lot of positive feedback. Also, really great results. This was focal hand dystonia. 70% of people improved on all of their variables, and the people that did more did better. And I think this is really, really important because I think in dystonia, you can't really expect to have these great changes and improvements without the level of practice. When we talk about neuroplasticity, we need a ton of repetition to make those changes. Okay, so now let's just talk again. This is so brief on cervical dystonia and focal dystonia with the evidence. It's so brief. So again, you can see some of those evidence-based recommendations for different sensory motor training and vibration and biofeedback and perceptual changes. This is something we work with a lot. We also love in clinically using the optimal theory, a motor control theory. I'll talk about some of the examples of that, doing different sensory stimulation and discrimination, a lot of autonomic training too. And I just want to hit on very briefly this SPRINT program, sensory motor perceptive rehabilitation integrated program. What I like about this particular study is that they looked at the addition of this program to a normal Botox regimen in cervical dystonia. And that's what I typically see in our practice, is that we're working with people alongside their medical treatment. And I love to time our treatment with the Botox to maximize the potential. And in this study, the people who had the additional therapy on top of Botox had a greater improvement. Really promising, really hopeful results. So that was the intervention evidence. I pulled a few images from different imaging studies, different neuroscience kind of background studies, mechanism studies for dystonia. And many of these are from my amazing colleague, Irene Kuo, who has done research in transmagnetic stimulation. She got her PhD at USC, awesome, and is now teaching and studying this. So we did a presentation together and she summarized this literature. I'm not going to go through all of it. There's a lot here. But what I want to point out is, if we're going to take a neuroplasticity approach, we need to understand what has gone awry in the brain. And I want to point out a couple of things. One is that we know in dystonia, there's a level of decreased inhibition. So too much excitement, not enough inhibition. And that goes directly into what we need to do then, is we need to improve the inhibitory capacity of the central nervous system, right? Another thing, so this particular one in hand therapy, we see a change in the cortex, the sensory cortex, and representation of the hand in hand dystonia. So I like to use the term smudge, like that sensory cortex is smudged. And so therefore in therapy, we need to unsmudge it. We need to improve the sensory discrimination within the hand. So if dystonia is a malplasticity, which is a great term that Irene has used in her presentation with us, then we need to undo that neuroplasticity and redo a positive neuroplasticity. And we take this approach, and that's really what's behind this gardening metaphor for cultivating central nervous system connectivity. And so let me explain this to you. Let's start at the soil. So the soil is optimized for neuroplasticity. This is why we take a team approach at Reactive. We're seeing this start to come out in literature as well. For the brain, we have to look at systemic health, immune, cardiac, nutrition, inflammation overall, sleep. So our OTs specialize in sleep. I don't know, if you have dystonia, you know that it's worse when you have a poor night of sleep, as are most neurologic disorders, as are most humans, right? So we have to optimize sleep. We want to help that person find a sense of safety, decrease fear, decrease that level of sympathetic arousal and, excuse me, stress arousal, and improve emotional health. We do this through a combination of neuropsychology and occupational therapy, but we also use these principles in physical therapy practice. And then fitness. So, just like that wonderful article from Nancy Beal and colleagues, having an overall fitness routine, this is what makes good soil to grow great brain connections. If we don't have these in place, if we don't have that optimized for neuroplasticity, we're not going to go anywhere. So we've got to get that in place. And then we can do all of these other great things. If we look at the compost, this might be addressing some of the biomechanical issues, muscle issues, so muscle tightness, if you've had cervical dystonia for a while, maybe joint issues. This is the compost. We're going to add this into the soil. The majority of this is brain training, watering, so getting that sensory input just the right amount, taking note of the weather. So, really looking at what the environment, culture, social, physical context, what are your beliefs about the dystonia? What are your perceptions? We have to take that into consideration because we do not function as islands here. And then pruning, reinforcing real positive connections and undoing that malplasticity. This is our gardening analogy. As therapists, we're really working at all levels. And I want to point out, it's not the same for everyone. So we have this pie chart. And what I would say is these pieces, the size of the pieces of pie change for each person. We do want to assess, as therapists, assess all of the pieces. And then we, along with the person, try to decide where to start and which pieces to attend to. Usually it's a little bit of everything, and different sizes for different folks here. Physical limitations is often the smallest, but if you've been to more traditional PT before, this might be all you've gotten, which I would say means you're getting only the smallest piece of the pie. So addressing some of the muscle and joint issues, maybe the nerve tension, some stretching, things like that. Important indeed, but not the whole thing. So we need to address motor control, so patterns of muscle activation, movement education, right left discrimination, using mirror therapy and feedback and all of those things, using the optimal theory of motor learning to drive actual learning changes. In the sensory realm, you'll see there's a pretty big box over here. We work on retraining that sensory system. We might use TENS and vibration. I use a lot of rhythmic movement and dancing to train the sensory system. Changes in posture, weights addressed to the body, using inversion, 2-point discrimination, kinesthetic awareness. There's so many things that we could do. It's not all the same for each person. In the psychosocial realm, we work really closely with our neuropsychologists, provide a lot of education, and there's an overlap with the autonomic in that nervous system calming, which might include breath and grounding. Humming is one of my favorites these days, and that rhythmic movement as well. But also, we might need to train the autonomic nervous system through exercise and staying really hydrated, and maybe even using compression, especially if somebody has some of the orthostatic hypotension. So we assess and then treat all of these according to the person. So I want to give you some examples here of different ways. So we might mobilize the shoulder here. We might use some taping. This is a person with cervical dystonia, and this was really, really beneficial. In the motor control realm, that mirror therapy, this was a guitarist um, who had full recovery with finger dystonia there as well. This is one of my favorite tools, which is a headband with a ball on it. And what I really love about it, it's an external focus for head movement, has been really, really nice to unlock some of that automatic movement. So, especially if you have cervical dystonia, if the focus goes from turning your head to moving the ball, it's really powerful. I love the Recognize app for looking at limb laterality. So, can you imagine and picture and rotate a limb in your head? In cervical dystonia, if you can imagine that in your brain, it was organized that this was the middle. So, all of your muscles fired and your head was pointing this way. But in the brain, it was organized that that actually was the middle. We would test that and then treat that to reorient the midline. So that would be an example of that kind of training. In the sensory realm, tens on the dystonic muscle, we use a lot of sensory discrimination, a little rice bucket like this. We might use different things attached to the fingers, like rubber bands. This is an example of a person wearing a laser headlight as an external cue on their forehead. And this is an example of that change in position and posture. This is a painter and could do the painting when lying on her stomach, for example. In the psychosocial and then moving into the autonomic realm, a big piece of this is really improving that window, widening that window of safety and a calm, secure nervous system. Really hard to do when we've been living in a pandemic. Breath is a major part of that, but working with a neuropsychologist through some of the different techniques can really be beneficial for individualizing this for a person. We do a lot of breathing, a lot of rhythmic movement. You've seen that come up a lot. It's sensory technique, it's an autonomic technique, it can even be motor control. So the ball is great for that. I love the harmonica, that the vibration through the throat with that, very similar to humming. And dancing, partner dancing is really great as well. Get some mirror neurons firing. So, just a few examples of how we might incorporate things based on this pie chart. But the bottom line, it's not one size fits all. There's not one program for every person with dystonia because that pie chart has different sizes. Some people might not have any autonomic involvement. Most people do, but some people might have a very small amount. So, what I want to give you are some really practical tips for optimizing neuroplasticity that you could do now. Number one would be sleep. And if you're struggling with sleep, I highly recommend talking to your doctor, looking for a sleep specialist. So, our OT, for example, has a specialty in lifestyle interventions for sleep. Start working on your fitness program. Now, if you're not doing anything, you can start really, really slow, but the evidence is for 30 to 45 minutes, 3 to 5 days per week of aerobic activity, really getting your heart rate up. You can start an autonomic practice. So, breath, grounding, that humming, singing, mindfulness. These would be a great place to start. Just start humming on your walks, maybe. Start a sensory practice. So do some things with your eyes closed. I love trying new yoga poses with my eyes closed and seeing if I can balance. Going barefoot on different surfaces, getting in different positions on your side, upside down, rolling on the floor. We don't do that enough as adults, I think, and getting on variable surfaces. And then finally, supporting your emotional health. I can't emphasize this enough. I do actually have one person I'm working with right now where 2 weeks ago was a really rough week for the dystonia. And I think she was just really ready to give up. And that next week, she got in touch with a psychologist, started working with them, got back in touch with her psychiatrist. And the following week, when I saw her, was like a new person and more movement in her neck than I've seen in years. So I just can't reinforce that enough of supporting and attending to your emotional health, not because dystonia is a psychological disorder, but because the circuitry is so influenced by our emotions, and and those two play just hand in hand. Um, okay, so I know that was really quick, just a very brief intro to dystonia and a neuroplasticity approach with an interdisciplinary team. What I really wanted to reinforce is there is evidence and hope for dystonia, for improvement, for recovery through a neuroplasticity approach. And it's an individualized approach where all of those contributing factors are considered and included in treatment. It's not just one thing. And that you can already, without even getting to a therapist, you can start in simple ways now. So I really want to thank the Dystonia Medical Research Foundation for inviting me to do this support group talk, asking me to record it as well. I leave my contact here for you to reach out if you have questions. And thank you so much for your interest in this topic. And I look forward to hearing from you. Thank you.